You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello there. Thank you for tuning in for our first episode of 2026. My name is Sandra Smiley, and I use she, her pronouns. I'm an uninvited guest on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh peoples, as well as a public health and preventive medicine and family medicine resident at the University of British Columbia. Did you know that here in Canada, out-of-pocket costs for medications result in hundreds of thousands of excess emergency room visits every year? The health outcomes that patients face depend enormously on their financial situation. If people can't afford to pay for the medications that they've been prescribed, their conditions are likely to worsen, landing them in the ER sooner or later. The social history is where we, as medical practitioners, are meant to gather information about income and other social determinants of health. In this episode, we're talking about how to make the most of that part of our conversations with patients. What's important to ask about, and what can we do with the answers? The guest on the podcast today is Dr. Ritika Goel, a family doctor and activist based in Toronto. Here's our conversation. And remember, if you don't have time to listen to the whole thing, you can skip to the pearls at the end of this episode or check them out in the show notes. Hello, Dr. Goel. Welcome to the podcast.
Thanks so much for having me.
Can you please tell us a little bit about yourself?
Sure. So I'm a family doc in Toronto. I've been involved clinically in working with a number of marginalized communities. So that's in the shelter system and drop-in system. I've worked with folks who use drugs and undocumented folks, trans, non-binary folks. Been very privileged to work with a number of communities and really kind of learn and support people through various struggles. I also consider myself an activist. I've been involved in organizing since medical school around a number of social justice issues, including around Medicare and anti-poverty more broadly, as well as specifically around support for migrant justice and also around Palestine.
Okay. And today, as you know, we're talking about the intersections of poverty and medical practice. Can you tell us what the science tells us about poverty as a risk factor, both for disease occurring or injury occurring, as well as those diseases or injuries getting worse?
The data is pretty clear in terms of the social determinants of health. We know that income is the number one determinant. It's not a binary factor. It exists on a spectrum. Essentially, the more income you have, the better your health outcomes are. And that's something that's borne out in the literature. It's very clearly borne out in terms of clinical practice and what I see day to day. I have a practice that includes, again, folks who are unhoused, as well as folks who own homes, people who are working, who are unemployed on social assistance, et cetera. And it's very clear in terms of how people present, what they have access to for maintaining their health, whether that's quality food, whether that's access to, ability to exercise, but also the history kind of trauma that people experience, whether that's Indigenous folks or Black folks or, undocumented folks, and the way in which that impacts their health. So you see it play out in a very clear sense in the care that folks are able to access and the outcomes that they have for various conditions and even the conditions that they develop. And that's what the data shows us. The data shows us that your likelihood of developing essentially all of the medical conditions is significantly higher the lower your income status is and your outcomes are worse.
Yeah, thanks for that. And I imagine that your training was similar. For mine, for sure, the social history was where we were expected to pick up issues related to poverty, food insecurity, housing insecurity, etc. And I'm wondering, is that what you see the social history being important for, or is the social history important for other reasons?
The social history is a really, really important tool. We talk about it as having sometimes just been reduced to asking people about, smoking and alcohol and drugs. But really, it's an opportunity to assess social context, which is the term that I like to use because you can see one person presenting with the exact same symptoms as another, and your actual ability to diagnose the condition, to appropriately recommend investigations, to appropriately recommend management, to know what the appropriate management should be, and come up with a plan that will actually be followed through and be effective, are all drastically impacted by understanding a person's social context. So, an example would be knowing if someone has drug coverage. If you don't know if they have drug coverage, you are very possibly going to prescribe them a medication. And we've got good data on this that 1 in 4 Canadians will not fill their prescriptions, either due to cost or because of insurance status. And if you don't know that information, you can do the best medical history and physical exam and advise investigations and come up with your excellent treatment plan. But if at the end of the day, the person can't fill the prescription, it really doesn't help. So understanding what someone's income status is, whether they're working, what their housing situation is, do they have supports? Are they living alone? Do they have family? What's their education level? Do they have a history of trauma? How does that impact what's happening for them in the appointment with you and also broadly in their life? And it doesn't have to be this long, extremely complicated thing. I think when people look at, for example, the If It Helps tool, which was developed really more as a teaching and learning tool to think about and reflect on the social history, they may feel like, well, I don't have time for this, right? I have all of these patients and everyone is under a time crunch. And how am I supposed to make their medical diagnosis and also understand their social context? But the reality is that we have to think about these things as integrated. And a few easy questions like saying, where are you staying right now? Or who are you staying with? Do you have drug coverage? How did you get here today? Do you have someone to help you get home? It doesn't have to be really complicated. And it also should very much be tailored to whatever your context is in terms of practice. So for primary care, the social history is something that I ask right up front on the first visit when I'm meeting a new patient. I use the If It Helps mnemonic. I put that into their social history on the CPP in the side panel. I update it if new things are happening. And it helps me in a myriad of ways. It helps me stay connected to the person. When they come and they're talking to me about something in their life, I can easily remind myself how many kids they have. Were some of those kids apprehended by CAS, right? Do they have a history of incarceration? Are there major life events that they've experienced that might be impacting how they're showing up that day that I'm not remembering? So there are just so many values to ensuring that we actually get a good social history.
I appreciate that you brought up the time crunch issue because as I was preparing for this episode, I was remembering some of my busier rotations and how so often the social history does get distilled down to do you smoke or not? It seems like an underutilization of that time and of the concept of the social history, given everything that it can tell you about a person's situation and also about things that you can do as a physician to support them. And that's a nice segue into a more fulsome conversation about the If It Helps framework. So, can you tell me a little bit more about that framework, what it is and how it differs from that checklist of questions that you are taught to ask in medical training?
Yeah, the development of the If It Helps framework actually came out of sessions that we do for medical students on poverty and health, and just recognizing that there wasn't a great, really comprehensive, detailed, critical tool that would promote reflection and would allow us to really sit with the breadth of what one can actually gather in terms of information around someone's life and their context and their social situation. So, it was never meant to be a checklist, and it's not a checklist, but it is supposed to be a way for us to realize that it might be helpful to have access to information about someone's income and their identity and their family status and, their history of trauma, education, employment, housing, all of the things. But the other piece that was really critical about the If It Helps tool is that we wanted to communicate that getting this information can also then help you recommend something practical to the person in front of you. And so that's why there's two columns. One column is around the questions you might ask, and the other column is around some resources that you might recommend. And so for me, knowing that a patient of mine is an immigrant from a particular country, for example, is actually really helpful in knowing that there might be certain services that are designed for particular communities. Or, knowing that they've got a legal issue might mean that I can help recommend them to a community legal clinic. And the thinking behind that was that often in medicine, because we are so trained to really primarily focus on the biomedical history and physical and investigations and diagnosis and plan, is to realize that there are things we can do, right? I think we don't necessarily like to ask questions when we're not sure what we're going to do with the answer. So the point of this tool was also really to think through, okay, there are a myriad of potential interventions that we can engage in if we have the answer to this question. And some of that might just be, hey, we're going to have the social worker talk to you about the fact that you have this legal issue that's come up. So it certainly isn't supposed to be an ask for the physician to replace every team member or to become the social worker, et cetera. But it does also recognize that a lot of times people are coming into contact with the healthcare system and they are primarily coming into contact with the physician, as well as the fact that we hold the power in the team. And often they won't see a social worker unless we are the ones that suggest you may benefit from seeing a social worker. So if you don't actually have that background information, you don't actually know what a person's true comprehensive set of needs are, you can't actually help to address them.
Yeah, it's a good reminder that we can do more with the social history than just recommend smoking cessation.
Yes, absolutely.
Not to get down on smoking cessation, also very important. But I've got the If It Helps tool pulled up in front of me, and I'm looking through the column on potential interventions. And there are things like, as you say, drop-in services, housing worker referral, legal clinic, etc. All places that could be appropriate to refer a patient to, depending on the situation that they're in and what social and structural factors are bearing down upon their health and well-being. Where would you recommend starting to get your head around the services that are available in the community that folks are working? And Google is a totally fine answer. Anything else?
Well, we have a much better tool than Google, which is 211. 211 exists in most of Canada and, in fact, has services in multiple languages running 24 hours a day. And it can be used both as a recommendation to a service that you give to the patient. So you could, if it's someone who you think can kind of navigate it, you could say, hey, you can call 211 and they can help talk you through this. Or you can search yourself on 211.ca, or there's a 211toronto.ca is usually what I will use. And that's incredibly helpful because this is an example that always sticks out to me. I have, kind of an elderly Chinese patient with dementia, and I wanted to recommend a service that might be focused on that specific area. Now, of course, that's something that you will see in Toronto. You may not obviously have such focused services, perhaps in rural areas or in other parts of the country, but it can be really helpful to just see even like what languages are available for certain things. Like there might be drop-in centers that exist and maybe you've got a few options, but 211 will help you figure out where is there a Hungarian speaking worker at a drop-in, or where are there groups like English conversation circles, or where are there groups for mental health that exist, etc. So it's just a really nice database that's out there. So that's where I would start. Beyond that, I think over time, wherever you're practicing and based on whatever your patient's needs are, I think some of it is also, again, if we don't ask the question, we're not going to know to go and look for the resource. So this happens to me every day, probably multiple times a day, either something comes up and I think, oh, well, maybe it would be helpful for this person to have access to a meal program or to go to something. And I might look it up myself, or I might have them look it up, or I might message a social worker on our team, which we're lucky to have. And I might say, hey, do you know what's available? For example, recently I had a child with severe autism, and we were trying to figure out if there were any in-home services that could be provided for respite for the mom. So that was a message, a question that I asked the social worker. But again, the reason why I come back so much to the social history and the social context is because if we don't ask, we won't know that the need exists and we can't work to address the need. And I've also found that a lot of times patients don't know that we could potentially assist with that need as well. So the number of times I'll have patients say, oh, like I've never really had a doctor ask me that. or I didn't think that was something that you could really help with, it again shows that we can't wait for people to come to us and ask us. And a great example of this is the income benefit system, because there are so many income programs that we are unfortunately made the gatekeepers of. And so I will ask my patients now that there is a new program called the Canada Disability Benefit, for example, which you're only eligible for if you've been approved for the disability tax credit. So I've slowly been asking all of my patients who are on disability whether they have been approved for the disability tax credit. And I will do that proactively because I know that this is a resource, and increasing their income, coming back right to what we talked about at the beginning, is going to improve their health overall. So that's, a proactive thing that you can also do if you know what resources are out there that could benefit your patients.
That's great. 211 is not a resource that I had ever heard of. I feel like I should pick up my socks here. This looks like a really great resource,
Yes.
bringing everything together into one place. So that's really helpful. We've been talking about how when you are sat across from a patient and they're talking to you about their challenges, what you can do for them. Let's zoom out a little bit and talk about the bigger picture. So, the structural factors that make it so they're having trouble affording their bills or filling the fridge. So, what I mean by that is advocacy. I know you've done a lot of advocacy in some of those bigger issues. One of the ones that I know you've been active on recently is Medicare. Yeah, let's hear about that. What is Medicare? And can you tell us a little bit about your advocacy on this topic, why it's important to you, and why it's important to your practice?
Yeah, there's a number of components there. So, of course, Medicare is that, broad public healthcare system that we have in Canada. And there are a number of fronts on which I think we have to, as healthcare providers that care about our populations and care about equity, have to be vigilant and have to be fighting. The first is maintaining a public healthcare system. There have been lots of threats to the public system in terms of particular governments that may want to privatize aspects of the system. So, maintaining kind of what the evidence really clearly shows us is that pooling our resources is a really efficient way of providing public services. And so the public system not only is the way to ensure that most people have access, it's also the most cost-effective way to help to run a healthcare system. And in Canada, we have this very particular experience where we sit next to the US. And of course, there is this, potentially large open market for American insurance companies. And of course, the US has a system that is largely a privatized system, other than Medicare and Medicaid and the VA for veterans, where they have large numbers of people who are uninsured that are, citizens and are American born, that are not eligible for Medicaid or Medicare, and therefore are either facing huge fees, pre-existing conditions that are denying them, or pre-approval that's required. So there's lots and lots of horror stories that exist in the US of people not being able to get the most basic care. So in Canada, we don't see that as much for the general population. Where we do see that is in the gaps in the Medicare system in Canada. So a big gap is around people who are uninsured. And so I've been involved in a lot of advocacy work around that population in Ontario and across Canada. And essentially, we're talking largely about migrants, so people who may be in Canada that are pending a humanitarian claim or pending spousal sponsorship, so folks who might be undocumented. And in some situations, there are people who've been here for decades and have been working. A lot of folks are in the construction industry, a lot of folks are in domestic labor industries, and are really kind of holding up our society, but at the end of the day are not able to access a lot of the services that our society provides. And in the context of us as physicians, the thing that shows up over and over is not being able to access the healthcare system. So we've been able to do some really good work. During COVID, there was a policy change that was allowed anybody, regardless of their immigration status and their health insurance status, to actually access care. And we were really pleased to see that and had really positive impacts. And then unfortunately, that program was rolled back. So there's been a lot of advocacy work with the Ontario Medical Association and the Ontario Hospital Association around really pushing for an alternate version of that program to become something permanent. So that's what we see in terms of, gaps for populations with Medicare. And then there's also gaps around what services we provide, with the biggest push in terms of policy change having been around pharmacare. So, we provide doctor and hospital services. That's really what Medicare is in Canada. And that's, of course, not what all of healthcare is, right? People need lots of things beyond doctor and hospital services. And I think the thing that comes up a lot, because it just seems so egregious given what doctors and hospitals often do is prescribe medications, that we would cover doctors and hospital services but not cover medications. And so there's been advocacy for years now around Canada expanding Medicare to include pharmacare, and there have been a number of iterations of kind of what that could look like. Again, similar to how Medicare is set up, the most kind of expansive and most cost-effective option is to have one public formulary that's across the country. And we have this experience already. It's just split up by provinces, where different provinces, largely most provinces, provide a public formulary to folks who are on social assistance and to seniors, and sometimes as well for kids. But these formularies don't talk to each other, and they also don't cover everyone else. And so the idea behind pharmacare would be essentially we would expand those programs and make sure that the one public formulary is available to everybody. So those are kind of some of the different areas of potential action when it comes to looking at Medicare in Canada.
Yeah, and this intersects with the bigger question that we're talking about today, which is poverty. Because obviously, if you are unable to pay for things like healthcare and your prescriptions, then you are less likely to avail yourself of them. And that's going to lead to negative health outcomes, right? Disproportionately at the population level for people who are income restrained. Is that right? Or are there other dimensions where these two things intersect, Medicare and poverty?
Yeah, absolutely. I mean, people who are lower on the income spectrum are, in many ways, they face barriers, obviously, even if they have insurance and even if they have coverage, whether that's just being able to navigate from a health literacy perspective, navigate in terms of people are working jobs that they can't leave to come to an appointment, or maybe they're late to an appointment and then the appointment is canceled on them, etc. But yes, in terms of medication access, the biggest challenge is that there is a large portion of the population that does not qualify for social assistance, but does not have a stable enough job to get medical insurance. And even for folks that do have medical insurance through their work, what insurance covers is quite widely variable. We do have something called the Trillium program in Ontario as well, which, if your medication costs are high enough, you can apply for that and that might cover you. But again, that doesn't really cover everyone. And so we have all these gaps. And I see that. I work in kind of a low-income immigrant neighborhood in Toronto, and I see a lot of families who have lived in this neighborhood for many years and are working jobs like working in a restaurant or driving a cab, things that are not going to provide you with decent income nor benefits. And so certainly there is a lot of conversation around taking medications and, being really careful about what medications we prescribe people because of how much they cost and whether or not they feel they can afford to actually take the medications, which is a really heartbreaking thing, and also just a huge equity issue and a huge issue in terms of what we're able to actually get people in terms of their health outcomes.
And on this topic of advocacy, is this social accountability? What is this concept that you're writing about, and how does it apply to physicians? How does it apply to the folks listening to this podcast, to medical learners and trainees?
Yeah, the idea behind social accountability is that for us in medicine, as learners and as practicing physicians, we have an accountability not just to the patient in front of us, but to society at large. And that means thinking about what services we're providing, where we're providing them, which populations we're serving, how we're serving them. I think, for example, about a push for myself to learn the skills of providing gender affirming care, or to learn around how to treat alcohol use disorder or opioid use disorder, that these are practical skills that you can prioritize learning to serve particular marginalized populations. Or you can work in sort of specific areas, or you can learn trauma-informed skills and make sure that you are providing culturally safe, equitable, anti-oppressive care to everybody that you see. And that's something that is part of the social contract between physicians and the broader society. Now, that's at the micro level. We also talk about the meso and the macro level, where the meso level is thinking about our relationship to the community. So that speaks to seeing trends, for example, in what our patients need, or understanding the importance of particular programs, particular educational things to ensure that we're serving the most marginalized communities, and also ensuring that marginalized communities are a part of our own planning, right? Like, how are our healthcare systems designed? Are we consulting communities? Are we ensuring that they are at the table? So that's kind of the meso level, is thinking, beyond the individual patient encounter. And then the third level is the macro level, which is that big picture policy advocacy level. And that asks you to reflect on kind of what are the policy changes that could actually improve the health of the populations that I'm serving. And how do I advocate for that? What does that look like? How do I make sure that I'm led by impacted and affected communities and uplifting their voices? How do I engage my fellow healthcare workers in also doing that broader policy advocacy work to make sure that we are making the upstream changes that are needed to actually improve the health of our populations beyond the direct care that we provide?
As we're talking, it's the 14th of October. So in Palestine, there is a ceasefire agreement that's recently been signed, and that is all over the news today. I want to talk about that, just noting the moment in history that we're in. I know you've done some advocacy around Palestine and recognizing the humanity of people in Palestine and what they have endured in terms of the blockade and the lack of access to very basic supplies like water infrastructure, healthcare supplies, etc. Is that advocacy also social accountability? Do you see that falling under that umbrella as well? Does that also intersect with other areas of your work? So the anti-oppressive practice. Yeah, let's hear more about that.
Of course. So social accountability means thinking about how we're accountable to society more broadly, and society doesn't end at Canada's borders. So, as physicians, as medical learners, when we talk about anti-oppressive practice, I think the biggest piece there is to be able to reflect on our power and privilege as physicians. We are among a group in society that has the ability to raise our voices and to see things move. And we have a great privilege in seeing how policy impacts what we see on the ground, and also being, having expertise in terms of interpreting public health data, in terms of interpreting kind of broader patterns, broader data that we see, and the health impacts of bigger policy decisions. So if we look at what's been happening in Gaza over the last 2 years, there's a lot of very clear data around, hospitals having been bombed, healthcare workers specifically having been targeted, and of course, the actual health situation for people on the ground that are enduring not just bombing, but have been enduring starvation. And really, the healthcare workers, our colleagues there, have been working in completely unimaginable situations, having to do surgeries without anesthetic at times, having to see children that they are treating not be able to heal because they have nutritional deficiencies, seeing illnesses that we've only ever heard about or read about in medical textbooks in front of you live. I can only imagine what our healthcare colleagues have been facing, aside from themselves also having been in the way of danger and many having lost their lives. So I think as a healthcare worker here in Canada, it behooves us to be aware, to learn about what's happening in other parts of the world, and also to raise our voices as it relates to our government and the role that our government is playing in maintaining, an oppressive situation anywhere in the world. So that has been really an important thing for me and for many others. But it has also been disappointing at times to see our healthcare institutions not necessarily taking positions and not necessarily wanting to publicly talk about this issue, even though it is laid bare for us to all see.
Thanks for this excellent interview. Is there anything else that you'd like to add that you'd like our listeners to know, or anything that you'd suggest they read more about, this being medical education? Yeah, anything else that you would add to cap us off?
I think it's important for us as physicians and medical learners to pay attention to what social movements are doing. Social movements have a pulse on who is facing marginalization and structural violence in our society. And, paying attention to when there are protests around things like Black Lives Matter or around reconciliation or around what's happening in Palestine. I think that raises our awareness and our attention to what may be an issue that we need to learn more about. I think turning to the arts is really important. For me, working with trans and non-binary folks or people who are unhoused or people who use drugs, these are all experiences that are not my personal experiences or my lived experiences. And so I have learned so much by listening to folks from those communities directly, whether that's through their own art forms of poetry or books or documentaries or whatever it is. And I think the more understanding that we have of someone's direct lived experience, the better that we can empathize, and also the better that we can serve them, and the better that we can advocate, not for them, but also with them.
Yeah, I love that. And that's a theme that's run through a lot of the interviews that I've done for this podcast. The value of looking outside of medicine for answers in medicine. Dr. Goel, thank you so much for being on the podcast today.
Thank you so much. This was really lovely.
That was my conversation with Dr. Ritika Goel, a family doctor and activist based in Toronto. Here are a couple of pearls that I took away from our discussion. 1. How effective medical care ultimately is highly dependent on a patient's social context. So their income, work, living situation, access to transportation, etc. Now, these are things that you can easily find out about in the social history, and that in turn will help you to tailor your investigations and a treatment plan to make sure that you're setting your patients up for success. 2. If we don't ask about these social factors, we won't know about them. And if we don't know, we can't take action. If you're not sure what might be relevant to ask about in your social history, you can lean on a tool like the If It Helps framework to guide you. But, of course, it's not meant to be a checklist. You should tailor your questions to the context that you're working in. 3. Like so many parts of medicine, optimizing the social determinants of health is a team sport. You personally don't need to action every potential task that arises from the social history. Once you've gathered the relevant information and worked with a patient to identify their needs, you can consult your colleagues in other disciplines or refer out to the services and providers who are best placed to help. 211 is a really good resource for getting your head around the social services available in your community. 4. As medical students, residents, and physicians, we are accountable to the communities that we live in. We have a responsibility to use our knowledge and our capabilities to respond to the needs of our patients and of society writ large. In practical terms, what does that mean? It can mean taking the initiative to learn new skills, getting involved in advocacy, and seeking to better understand the perspectives of the people that we serve on the way that healthcare is delivered. 5. Connecting with people on topics and in spaces that matter to them outside of healthcare will make you a better doctor. Build empathy and understanding by exploring the experiences of others through, for example, the arts, film, poetry, and literature. Social movements can also act as a compass, directing you toward issues that matter and on which your knowledge, skills, and voice as a physician might be needed. Many thanks to our guest, Dr. Ritika Goel, and to you for listening. Please let us know what you thought of this episode by leaving us a comment, reaching out on social media, or filling out the survey in the show notes. This has been episode 36 of Just Medicine. I'm Sandra Smiley.
Thanks for tuning in to Just Medicine.